I've spoken here since, first time I spoke here was in 2002, I believe, 17 or 18 years ago. And probably the second or third conference or support group lecture that I've ever given was here in 2002. And so it's nice to see, it's always nice to come back. This is like a home to me. And I'm glad to see the group is thriving, and you guys are doing a great job helping helping society learn more about prostate cancer, especially guys who are sometimes they feel lost, and having a group like you guys is really really thankful for that. So the prostate cancer has always been a very complicated condition because it's really not your typical disease, and that's why I could spend full time in one cancer. I don't have to do any other cancers because this cancer is so complicated. But we're always trying to figure out ways to help patients understand their condition better, perhaps help them concentrate their efforts on learning about their specific situation without being bombarded by this overwhelming amount of knowledge that is, especially on the World Wide Web. So, traditionally we talk about prostate cancer as low risk, intermediate risk, high risk, but those are kind of nebulous terms, and sometimes defining them is not even that easy. And so, not only for doctors, but for patients. So, we came up with a color-coded system with different shades of blue, and hopefully this will help patients a little bit more in terms of understanding their own specific situation. So the goal of today's lecture is to go over the various stages of blue, and also to review and update everyone on some of the newer concepts in prostate cancer management. So we'll start off with a little prostate exam. Does anyone want to volunteer? I think I'll pass right now. So it's very important to understand one's own staging, because prostate cancer, the severity of prostate cancer varies tremendously. It could be very, very benign acting, or it could be very aggressive and life-threatening. So it varies so much. So it's not just one condition. You have prostate cancer, and that's it. It's not like brain tumors or liver cancers. So prostate cancer is quite variable. So therefore, every treatment, everybody has their unique optimal pathway to success. So the goal, as I said earlier about these 5 stages of blue, are to help patients concentrate their time in terms of research, help patients objectively categorize themselves, and also help patients discuss with their doctors on a more level playing field. So some of the reasons that patients have trouble with managing and getting good prostate cancer care is multiple reasons. I'm just going to read them off right now. It's not like other cancers, like I said earlier. There's doctors, often patients, when they see a doctor, that doctor only specializes in one type of treatment. So, for example, the surgeon who diagnoses the patient usually only specializes in surgery. So he's not as equipped to talk about radiation therapy or hormone therapy or chemotherapy. And also, since he's specializing in that one field, he'll probably have some biases in whatever he does. In fact, there are some doctors, and also not every doctor specializes in every stage of cancer. So some doctors are really good at diagnosing prostate cancer. Some doctors are really good at treating initial stage prostate cancer. Some doctors are better at relapse. Some doctors are better at treating metastatic disease. I joke around telling patients that I specialize on the left side of the prostate and Mark specializes on the right side of the prostate. But there is a lot of subspecialization in this field. So, and ultimately, oftentimes patients are left with the onus of making the decision themselves. Doctors they meet a bunch of doctors and then they have to make their final decision. So there's a lot of pressure there. So obviously, there's information overload in this very complex staging system, intermediate, early, low risk, intermediate risk, high risk. So another detail that patients aren't really aware of that I'm going to try and explain today is this concept of invisible metastases, micrometastases. Of course, there's a little bit of lack of perspective when patients are confronted with prostate cancer. There's an emotional factor when making a decision, and they are only coming from a patient's only coming from his own perspective, whereas hopefully learning more about the stages, they'll get a better idea of what treatment is better for them, and not base their decisions on emotions. Of course, making this decision on treatment is so big because the side effects could impact upon one's life forever. And most of the guys are diagnosed, they have another 10, 20, maybe 30 years of life, and if they make a wrong decision, their quality of life could be completely ruined. How's that for pressure? So let's define metastases, and that's an important factor in today's talk. The definition of metastasis is prostate cancer cells that are growing outside the prostate. So not only cancer cells, but it has to be prostate cancer cells growing outside the prostate. These cancer cells could grow in the bones, could grow in the soft tissue like lymph nodes, could grow in the organs like lung and liver. And these are different from lung cancer, liver cancer, bone cancer. These are prostate cancer that's gone to those organs. And then we'll talk more about this concept of micrometastases. It's also a caveat is when a person's PSA is going up, cancer in the bone that came from the prostate makes PSA. So that's another differentiating factor between prostate cancer metastases in the bones versus bone cancer, for example. So PSA is not just made in the prostate, it's made by prostate cancer wherever it may be. So how does metastases impact one's life? Well, of course, they can cause organ damage, organ failure. It could cause loss of the inability to make blood cells when there's so much cancer in the bones. It could affect the liver, and when the liver fails, a lot of things happen. It could cause shortness of breath and coughing and chest pain if it's in the lungs. And it could cause, so visible cancer is dangerous. Okay? But micrometastasis, cancer that we do not see, doesn't cause anything but mental anguish. Okay? And it doesn't cause symptoms, and it's not dangerous. If you can't see a cancer, it's not going to kill you. However, it's important to know this concept of micrometastasis, which we'll talk about. So, of course, these are examples of metastatic disease. This is a bone scan, and these little black dots are signs of cancer in the bones. On this CAT scan, and this is the liver. These are tumors that have gone to the liver. And this is a PET scan. You see these white areas that lit up. These are cancers in the lymph nodes and some cancers in the ribs and the pelvis. And these are cancers that are from the prostate that is seen on a PET scan. So bone scan, MRI actually, and a PET scan. So of course you can imagine these causing symptoms. So when we initially see a patient, it's very important to determine, of course, typically if a patient presents with abnormal PSA, he gets a biopsy, he's told he has prostate cancer, we know that there's cancer in the prostate. The big question is there a cancer outside the prostate? Like, for example, these little dots here. Now, of course, if we do a scan and we do not see anything, that means we do not see visible prostate cancer. Does that mean we can guarantee the patient that he does not have invisible prostate cancer? No. So, cancer can be invisible, and that's what we call the micrometastatic disease. Now, so when we initially treat a patient's prostate, we could tell them, oh, we could be successful at treating the prostate 90 to 100% of the time, but is your cure rate 100%, 90 to 100%? No, because your cure rate is actually, your cure rate of the prostate cancer within the prostate minus the likelihood that you have invisible prostate cancer outside the prostate. Okay. So let's say, I'm going to guess, this patient has a 10% chance that there's actually cancer outside the prostate. And let's say his cure rate here is 100%. That means his true cure rate after we treat the mothership is 100 minus 10%. So his true cure rate is 90%. If I tell the patient, oh, I think you have a 50% chance you have invisible stuff out here, then when I treat the mothership, his cure rate is actually 100 minus 50. Does that make sense? Okay. And so that's an important factor that patients are not told about. You know, they think, oh, just get it out, and I'm done. Well, you may be done if your chances are 50%, then there's a 50% chance you're done, but there's a 50% chance you're not done. And that's why after we do surgery or radiation or whatever we do to the mothership, we still check PSAs afterwards. Not because we want to see if it was successful here. We're trying to see if there's invisible stuff that is growing that would be manifested by rising PSA. Remember, the PSA cancer out here that is from the prostate will also make PSA. Make sense? So yes, you got to keep this in mind when we think about when we treat the local disease versus systemic disease. And sometimes when we treat the local disease, we add treatment for the whole body, thinking that there might be some stuff out here, so we might have to treat the invisible stuff as well. So, let's see here. So this slide basically kind of summarizes what I just tried to say. Of course, invisible metastases is not as serious as visible metastases. We cannot see it. That's the definition of micrometastatic disease. You don't feel it, and you can only really estimate whether a person has it or not. We can't tell them whether or not he has it or not. If I did a scan and I saw a spot, then I tell them you have a metastatic disease. But if I see a scan and I don't see a spot, then I have to estimate what the likelihood he has invisible spots. And that's what this stage of blue will help us get a better estimate. Okay. So the 5 stages of blue are as follows: sky, teal, azure, indigo, and royal. So in the olden days, sky would be, in the traditional sense, be called low-grade prostate cancer. Teal would be called intermediate. Azure would be called high risk. Indigo would be relapsed prostate cancer. And royal will be called metastatic advanced prostate cancer. So hopefully once you can look at your own situation, you could categorize yourself into one of these categories. And let's go into that in detail. So these are some of the ways we help. Let's go back one. Okay. So the way we determine the color or stage of prostate cancer one has is we look at the biopsy information, like the Gleason score, the PSA, which is the blood test that we draw from it's a blood test. The DRE is a digital rectal exam. So in general, you think about the higher the PSA, the higher the Gleason score, The larger, the bigger the tumor seen or felt on exam, the higher the shade, the darker the shade. Okay. So, we try to, we can help determine the stage by basically asking ourselves and the patients these questions. What is your PSA on diagnosis? Is it under 10, between 10 and 20, or above 20? What is the highest Gleason score on your biopsy? So if you have six pieces that were involved, you have to find the piece that had the highest Gleason score. 6 is good, 7 is intermediate or teal, and 8 or higher is azure. What did we find on digital rectal exam, which is the finger exam? A small lump, no lump, medium, larger lump, or a very large lump that you feel, or you can see extracapsular extension or seminal vesicle involvement. And in terms of imaging, what we could help determine the color by doing an MRI or an ultrasound to look at the prostate. We could do an MRI to look at the lymph nodes. We could do a bone scan to look for cancer in the bones. We could even do PET scans, like the scans I showed you guys earlier. So these will help us determine where the visible cancer is. Again, this is talking about visible cancer. Okay? Did a patient have prior surgery or radiation? And is the PSA going up? And is the PSA going up despite the first line of therapy, hormone therapy? So you could go on this website and calculate your color just by all those questions are on this website. And probably will be on the Fullerton support group website. So you can also, these are some books that you can refer to. This is Dr. Scholz's new book, and this is the PCRI staging guide booklet. So a little bit more about biopsies, which is kind of like the gateway to prostate cancer. And so let's talk a little bit more about the traditional and the more novel approach to diagnosing prostate cancer. Traditionally, 30, 40 years ago, you present with prostate cancer with back pain, you can't urinate, some sort of symptom related to visible high volume cancer. Okay? But about 30 years ago, the PSA blood test was discovered, and it was a test that, when elevated, was a fairly useful test to tell you to go look for prostate cancer before you feel it. So a lot of men, got PSA testing, and they were then stratified into, might they have prostate cancer, or, oh, don't worry, they probably don't have prostate cancer. So with the PSA testing, the next step that a patient would go through is what we call a random biopsy. So the doctor says, oh, your PSA is high. We think you might have prostate cancer somewhere in your prostate. So what we're going to do is we're going to randomly poke your prostate kind of in a systematic way to hopefully catch it. So before, it used to be 6 cores randomly spaced out. And then they thought, well, 6 is not that much, and we're missing a lot of prostate cancers, so let's do 12 cores. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So 12 seem to be the accepted number of random cores now. Some doctors say, well, 12 cores all in the back of the prostate, you're still going to miss it. So you got to do 12 cores in the back and take an extra 2 to 4 in the front. So now we're up to 14 to 16 cores. So imagine telling a lady, oh, your breast cancer blood test came back abnormal. Can we randomly poke each breast 12 times and hope we find cancer? So I think the first answer was, heck no. How about a mammogram, or how about an ultrasound? And let's see if we see something before we randomly poke. So thanks to some of the pioneers like Dr. Duke Bond, who specializes in looking for a cancer on ultrasound and then doing a biopsy in that suspicious lesion, the logical concept of finding a spot and then biopsying it rather than throwing out a wide random net to biopsy came about. So targeted biopsies is pretty much the new way to go. And in the last couple of years, more and more physicians are accepting targeted biopsies. The argument is, oh, targeted biopsies might miss some cancers. Well, true, but random biopsies miss even more. So now people are saying, well, you know what? I think that's true. Targeted biopsies seem to be the more logical way. The other reason why targeted biopsies are becoming more popular is less pokes equals less side effects and less pain and less suffering. So usually we don't want our patients to suffer. So that's becoming more accepted. Finally, the literature and the research is finally catching up to logic. And now we're beginning to prove once and for all that targeted biopsy is a much more efficient and logical approach. This is a big study that came out last year that basically took 500 men who had abnormal PSAs and randomly split up half of them to do a random biopsy, the good old-fashioned way, 12 cores. And then the other half of the men were randomly assigned to doing an MRI, and if you see a spot, taking a sample. So what they found was, and then there's also a concept about significant and insignificant prostate cancers. The cancers that are not dangerous versus the cancers that might be dangerous. So what they found that was people who had an MRI and then underwent an MRI-guided biopsy, about 1 out of 3 of these men were found to have clinically significant prostate cancer. And because a lot of men were allowed to skip the biopsy, or they didn't have less cores taken out, less men were diagnosed with what we call insignificant prostate cancer, which is actually a good thing. You don't want to diagnose insignificant prostate cancers, actually. Okay? So, as opposed to if you did the random biopsies, only 26% of the men were diagnosed with significant prostate cancer. So the yield for diagnosing or catching the significant prostate cancers was higher with the MRI. The yield of catching insignificant prostate cancers would be higher with the random biopsies. One would argue that catching these insignificant cancers is actually not doing a good service to the patients. The other thing was they noticed that intuitively there should be less side effects. So in fact, there were less side effects. People with MRI-guided biopsies had less blood in the urine, less blood in the semen, less prostate pain afterwards, less rectal bleeding, less temporary erectile dysfunction, and more importantly, much less likelihood of developing sepsis. So one little detail that patients are sometimes forget, that these biopsies can kill you. You could undergo a biopsy just to find cancer, and you could get a blood infection because you're introducing bacteria from your colon into your bloodstream. So that's called sepsis. Sepsis is you get a blood infection, you get a fever, your blood pressure plummets, you go to the hospital for IV antibiotics, sometimes you get to the intensive care unit. Occasionally, you die from it. And that happened at St. John's in Santa Monica a few years ago. A very prominent, well-to-do hospital and well-to-do patient underwent a biopsy and died. So this concept of sepsis it doesn't happen often, thank God, but 4 men in the group of 250, a little bit over 1.5%, developed sepsis. as opposed to one patient in the MRI guided. You're taking, 1/3 less cores, so 2/3 less cores, so that kind of makes sense. These numbers make sense. Okay. So we're getting better at choosing which men get biopsies and which men don't. And these are other things that can help a clinician decide whether or not the patient needs a biopsy, either urgently or maybe it might be safe to watch a little longer. We don't have to reflexively poke around just because the PSA is a little off. So an MRI, an ultrasound, now there's genetic testing of the urine. You guys heard of genetic testing for colon cancer, the Cologuard stool test? So that's a really good test for colon cancer. These are pretty good tests for prostate cancer. So these are urine-based genetic tests. There's also a blood-based test called the 4K score. So let's jump through let's go past my biopsy discussion and go back to the topic of the day, which is the staging, the color staging of prostate cancer. So let's talk about SKY, which is what we call low-risk prostate cancer. And we broke the subgroup of SKY into 3 subgroups. One is low SKY, basic SKY, and high SKY. Low SKY is you have Gleason 6 cancer only, and you only have, if your doctor did take 12 cores, you only have maybe 1, 2, or 3 cores that have cancer. The cores that were involved are not very involved with cancer, so less than 50% of the piece that was removed will have cancer. So this would be a low SKY and what we call the original Epstein criteria. High SKY would be patients whose PSA is disproportionately higher than what we expect based on the prostate volume. That's called the high PSA density. And more than 50% of the cores are involved. So let's say you take 12 samples and 8 of them had Gleason 6 prostate cancer. Well, Gleason 6 is good, and let's say the PSA is below 10. Everything is good, but there seems to be a lot of cores with prostate cancer. So this would still be a low-risk SKY category, but perhaps the higher subgroup called high SKY. So our proposed general recommendations for how to manage SKY patients is for low and basic SKY, we recommend active surveillance. If you have high SKY, active surveillance is still probably recommended, but one may also consider something like focal therapy. So this was a study published in 2016 in the New England Journal, where they called this the PROTECT trial, where they compared 500 men, in a 1,500 group of men, a third were divided into an active surveillance group, a third were divided into a surgery group, and a third were divided into radiation. And these are all SKY, or mostly SKY, or maybe low TEAL patients, low risk cancers in general. And what they found was over a 10-year follow-up, there really wasn't a dramatic difference in prostate cancer deaths. 8 out of 500, 5 out of 500, 4 out of 500. In other words, even if you did surgery or radiation, there's a risk of dying of prostate cancer because probably there were some micro metastases that were not visible. And yes, if you did active surveillance, there is a slightly higher chance of dying of prostate cancer. 8 versus 5 versus 4. But when they looked at statistics and they measured the 10-year survival rate, the difference was only about 99.6 versus 98.8. They actually called this statistically insignificant. Okay? It is true that more men on active surveillance progressed because you're watching the cancer, so you're letting it progress. So there were more men with progression. Okay? But still, if you did surgery or radiation, there's still a risk of progression. After 10 years, yes, there were more men with visible metastases. So almost a 2 to 3 to 1 ratio of higher likelihood of having visible metastases. So there is a price to pay, potentially, by doing active surveillance. You do run a slightly higher risk of having metastases. Remember, the absolute number is 33. The percentage is only about 6%. So if you say, oh, you can do active surveillance, you don't have to do surgery, but in the next 10 years, there's a 6% chance you will have visible metastasis versus a 3% chance. So, you should think about it. Is doing surgery or radiation and its side effects worth having a higher risk of, a lower risk of having visible metastases without a big difference in dying of prostate cancer? And remember, a lot of guys, unfortunately, still die of other things. So, in fact, the overall survival rate, or the total number of deaths in all three groups, was very, very similar. Not because prostate cancer kills everyone equally, but everyone dies of other stuff. Okay? So, in the active surveillance, it's pretty safe in general. And that's why it could be offered to patients. And you got to balance treatment with potential side effects. So if you do surgery, there's in this study, there's a high likelihood, about 80% chance, you will be impotent after 3 years. If you do radiation, or it's still in the 60s, if you do active surveillance, because we're all getting older, we can still get impotent if we do nothing to our prostates. But this is the biggie right here. The risk of incontinence with no treatment is only about 5%. So, but if you do surgery, the risk of incontinence is about 20%. And with radiation, there's no increased risk in incontinence. So, treatment versus no treatment. The next category I'm going to talk about is the intermediate risk category, or what we call TEAL. And TEAL is categorized as, Gleason 7 disease, or a PSA of 10 to 20, and/or a moderate-sized nodule on exam. And there are some other things, or moderate-sized lesions seen on ultrasound or MRI. A low TEAL patient will just have a little bit of Gleason 7. A high TEAL patient will have more Gleason 7 and more Gleason 4 component, 4 plus 3 as opposed to 3 plus 4. Basic TEAL is maybe you have a medium amount of Gleason 3 plus 4, or but not having 4 plus 3. So these are the three subcategories of TEAL. So with patients with low TEAL, we actually may still consider active surveillance, especially if a patient has somewhat limited life expectancy, or he's a little older, we're worried that treatment might be too harmful for him, or he has other medical conditions that are probably more serious than the prostate cancer. We can still consider active surveillance. But treatment is often discussed or recommended. If you have basic TEAL, treatment would be seed implants or radiation therapy delivered via the hypofractionated approach. This would apply to low TEAL as well. If you have a high TEAL prostate cancer, you might need radiation or seeds, but you might need to throw in a short course of hormone therapy. Or surgery is still an option as well. The difference between SCI and TEAL is, of course, these details I talked about, but what all this means is, with these factors, we think there's a higher risk of invisible metastatic disease. So there's higher risk of micrometastasis and a lower likelihood of cure when you guys do treatment. So it's a little bit more serious, and therefore we don't recommend doing nothing traditionally. All right. Little new data on hypofractionated radiation therapy. In the olden days, when I started, radiation was delivered over 8.5 weeks, 42 sessions, 5 days a week. Recently, they did some studies showing that you could deliver it, what we call a hypofractionated approach, meaning deliver the same amount of cancer kill in less visits. So there was a study showing 4 weeks of radiation was equivalent to 8 weeks of radiation. So nowadays, the approach is between 4 and 6 weeks of radiation. It turned out that in this study in 2008, not only was hypofractionated radiation therapy equal, but in this study, it was even better than conventional 8.5-week radiation, a lower relapse risk. Now there's some new studies that were presented last year that you could get away with 5 visits of radiation instead of 42 visits. 5 visits of radiation therapy at 9 years has a very good, still has a very good cure rate, 80 to 90%. So the move in radiation therapy is to do lesser and lesser visits and still get the same success rate and the same low likelihood of side effects. I didn't include a slide on hydrogel, but there is a product called SpaceOAR Hydrogel, which is a silicone-like jelly that is injected into the space between the prostate and the rectum. And that will separate or give enough space so that when the radiation beam comes from the outside, there's a much lower likelihood of damage to the rectum. So now with the incorporation of SpaceOAR, I feel even more confident that one could do 5 visits over 2 weeks and be safe. So the next group, or the next color category, is the color code AZUR, or higher risk patients. And these are patients that are described or characterized as having a Gleason score of 8, 9, or 10, a higher PSA such as 20 or above, a larger tumor either breaking through the capsule or invading the seminal vesicle. And again, low AZUR has basically lower volume Gleason 8. High AZUR is either very high volume or very high PSA or Gleason 8 or 9 disease. So these patients, in general, AZUR patients have a 40 to 60% chance of having invisible metastasis. So I would say SKY is probably 10% risk of invisible metastases. TEAL is 20 to 30%. AZUR is 40 to 60%. So these patients have almost a 50-50 chance of not being cured when you treat the prostate only. So therefore, when you manage patients with AZUR stage, not only do you need to treat the prostate, which we recommend doing seeds and in combination with radiation, we also have to incorporate 4 to 6 months of androgen deprivation therapy, otherwise known as TIP, or up to 18 months for the basic AZUR. And if we're really, really concerned, we would do up to 36 months of androgen deprivation, plus a stronger anti-hormone therapy called Zytiga. So in other words, the more concerned I am that there's stuff outside the prostate, the stronger the systemic treatment I would recommend. And this is systemic treatment. So this was an update published in JAMA comparing the cure rates of AZUR patients, or in that paper they call it very high-risk patients, when they did surgery versus radiation versus seeds plus radiation. And based on the study, at 7.5 years for 1,800 men, the remission rate of the combination group was 90% as opposed to 80% for the other two groups. So there is an improvement in cure rate with the combination of seeds plus radiation. And hence, for our ASR patients, we recommend this group, this combination, over radiation by itself or surgery by itself. Indigo, color stage indigo. And color stage indigo is basically relapsed prostate cancer after treatment to the prostate itself. So usually it's relapsing only manifested as a rising PSA, and so when the PSA is rising after surgery or radiation, for example, we start looking for cancer. You know, where is this PSA coming from? And if we do scans and we find out that there is cancer in the lymph nodes nearby, this is what we call high indigo. If a patient did all the scans and we don't see any cancer anywhere, then we have to decide, do we think that this invisible cancer is only in the prostate area, which we would call low indigo, or do we think it might be in the prostate, but there's a decent chance there's some invisible cancer cells outside the prostate? So this is based on a lot of factors that the doctor has to compute, but one of the things is when one does his treatment, how fast is the PSA rising? Is it going up really quickly after surgery? Has it reached 2 or 3 or 4 or 5? What was the original Gleason score? Is it doubling every month? So if all of those are kind of bad and yet we do not see cancer yet, then that patient would be a basic indigo. If a patient has a low PSA, it's rising very slowly, the Gleason score was 7 initially, and the PSA is only like 0.3 or something, then we're thinking, well, it might only be in the prostate bed and we're confident it's not elsewhere. So it's important to distinguish local only or local plus systemic, or versus proven metastasis, local metastasis, because the treatment is different. So for patients where we really think it's only in the prostate bed only, we could consider doing more treatment to the prostate area. So after surgery, we do radiation. After radiation failure, we could consider cryosurgery, HIFU, or even surgery. Or, if the PSA is very slow rising, and we could even consider watching it. You know, don't do any more treatment, just watch it. So the first two options is, when you do radiation after surgery, you're going to go for cure again. Okay? If you do HIFU after IMRT, you're going to go for cure again. So you're doing a second thing to the prostate area, which has its own ramifications. You're taking a gamble to try to get cured, but there might be a price to pay in terms of side effects. So some people say, well, I tried to get cured, it didn't work, things don't look too bad, I'm going to leave it alone. I don't want to do anything else to that area. So that's why people would do observation. Okay? Some patients, they don't want to try something else again to the prostate area, but they don't want to do nothing, then one may consider intermittent androgen deprivation therapy, intermittent TIP. So this usually involves 9 to 12 months of hormone blockade, and then you get a few years of no treatment, you observe 9 to 12 months of treatment. So kind of like on and off. You're kind of like managing, keeping this cancer contained. On the other end of the spectrum, the high indigo patients, where you've already done your scans and you do see cancer in the lymph nodes, you're actually still can go for cure. But it's going to be a little more challenging, but you could still go for cure. If you had surgery, you do radiation to the prostate bed and the lymph nodes. If you do radiation, if you had radiation, you treat the prostate bed again, but you still radiate the lymph nodes. And then you also do hormone therapy anywhere between 12 to 18 months. And you may also add the Zytiga again. So if you're really aggressive and you want to go for cure, even when the cancers come back in the lymph nodes, you got to pay a bigger price. If you decide not to go for cure, you suppress it with intermittent hormone therapy. Notice that I didn't say you just observe. In this situation, you do not just observe. Okay, so the last color category is what we call royal. And royal is defined by patients who have cancer in the lymph nodes outside the pelvis, more distant metastases, or cancer in the bones, liver. That's all considered royal. The other category for royal is what is castrate resistant. So if you're on Lupron or Eligard or Firmagon and the PSA is rising, you're considered royal. So on treatment, low testosterone, if you have no visible cancer but yet the PSA is rising, this is called low royal. If you only have a couple little spots, basic royal. And if you have more than 4 spots, you're what we call high royal. Castrate-resistant disease with no metastasis, a little bit of metastasis, or a lot of metastasis. And there's a different management approach to each one. If you haven't had androgen deprivation therapy and you have visible cancer, then you're considered basic royal if you only have a few spots, high royal if you have more than 4. And we'll talk about treatment options for each subcategory. So, if you have castrate-resistant disease and there is no visible cancer, these are your options, Erleada or Xtandi. And this is some data presented last year. If you take Erleada, you basically delay the time that it takes for the cancer to become visible. So what they did was they took a group of men, over 1,000 men, and half of the men with castrate-resistant disease were given a sugar pill, and the other half were given Erleada. And after a long follow-up, the average time to seeing visible cancer was 2 years later if you took Erleada. So if you take Erleada, you're not going to see visible cancer for 2 years longer than if you did nothing. There were some side effects, and these include rash, tiredness, and hypertension, among some other ones. Another drug called Xtandi, they did a very similar trial, 1,400 men, and again they found about a 22 months difference in the time to development of visible cancer. Side effects of Xtandi, tiredness, blood pressure, sugars are a little bit high, tiny risk of seizure, falls and fractures. Okay, so back to the men who present with metastatic disease but who have never been treated with hormone therapy. Well, if you have a few spots like these, or this one on bone scan, or PET scan, and this one on the bone scan. So there's not two, this patient has what we call oligometastatic prostate cancer. He doesn't have widespread, he just has a few. And so for someone with a basic royal situation, we do treat the patient with androgen deprivation therapy, but we also do radiation directed to those spots, knock those things down. And then we also add Zytiga. For patients who have a few spots, but these develop despite being on Lupron or Eligard or Firmagon, then this is castrate-resistant disease with visible cancer, not castrate-resistant disease in visible cancer, but visible cancer. You still zap all those spots, but this time we would recommend Provenge, and then we add Zytiga or Xtandi. And usually this combination works for about 1 to 3 years. This combination should work for about 2 to 5 years. This is what we call high volume metastatic disease. It obviously doesn't look very good. This is a high royal case. And for this patient, if he never had hormone therapy and he presented with this picture, I would say, hurry up and start hormone therapy, but this time add Zytiga, but also consider using chemotherapy early. Not later, but earlier. And this, even with this approach for someone like him, you control the cancer for 2 years on average, but I've seen guys like this alive and well 10 years later. So it can happen. People can be treated very successfully despite all this cancer. So the key, though, is being aggressive and using a lot of these drugs that used to be reserved for very end-of-life cases. Use them early, and you'll get a bigger bang for the buck. If you have multiple metastases like that prior scan I showed you, and this happened despite androgen deprivation therapy, meaning castrate-resistant disease, then you give Zytiga or Xtandi, and then you also have to start considering these other options such as radiopharmaceuticals. The most popular one right now is what we call Xofigo, radium-223. Chemotherapy, Taxotere or Geftana, which is the 2 most common chemotherapies. And now we're beginning to incorporate immunotherapy. But the only approved immunotherapy is still Provenge. So the next few slides are mainly about some of the newer treatments that we use for metastatic castrate-resistant disease when many of the other stuff stopped working. So one drug is this newer radiopharmaceutical called lutetium-177. And this group presented its initial data in 2018, but they gave an update about 2 weeks ago on this lutetium-177. This is a bar graph of the first 30 patients. So everyone who got treated got a bar. And if your PSA dropped with the treatment, the bar is blue and below this line. So if your PSA went up, then the bar is above the line and red. So this is let's see, 50% PSA rise or above versus 30%, 50% drop versus 30% drop. But the take-home message is there's a lot of people who respond to this. To give you the exact numbers, of the 50 men who got treated with this treatment, and most of these men have had chemo, they've had Zytiga, they've had Xtandi, and their average PSA was like 100 something. And 32 of the 50 men had a greater than 50% PSA drop. So 2 out of 3 men responded to this treatment, which is actually very, very good. Of the 27 men who had visible lymph nodes, about half of these men, the cancer was measurably smaller. The downside is this treatment is given every 6 to 8 weeks for 4 treatments. Once you stop the treatment, the cancer does come back over about the median time that it coming back is around 7 months. So it's a temporizing treatment, which doesn't work, but it doesn't work forever. Hopefully this might be something we use earlier in the game, which will get a bigger bang for the buck. But interestingly, of the men that relapsed, if you gave the treatment again, there's a very good chance it works again. More than half of the men would respond to the same treatment. Whereas a lot of other drugs, when you retreat with the same drug, it has a much lower chance of working. So very promising compound, and I anticipate it getting approved in about 18 to 24 months. This is just an example of one of my patients. He didn't have widespread metastases, but he had a PSA of 36, And he had a smattering of metastases, about 15 little spots. And many things had stopped working for him. We gave him lutetium. After 3 treatments, his PSA dropped from 38 to 8. And all the spots disappeared. So he's very happy. I said, why don't we just stop? Don't do the 4th or 5th. Take a break. He says, no, I want to keep going. I don't care if I'm 91. I want to keep going. So he got another treatment. His PSA today is 2. Yeah, from 30-something. So I'm hoping, because he had such an amazing response, he might get maybe 12 to 18 months of remission.
Is that indicative of the general population that would use that drug?
I would say, like I said earlier, about 60% of men will get a drop of at least 50%. I think he's doing better than the average person, for sure. Yeah. So another compound, this is a drug called Keytruda, an immunotherapy PD-1 inhibitor that is used for kidney cancer, bladder cancer, lymphoma, lung cancer, melanoma, head and neck cancer, and stomach cancer. So really successful drug. If you own stock in Merck, you'd be doing pretty well. They're putting a lot of resources into prostate cancer, and the main trial for prostate cancer is called Keynote 199, and they treated over 200 men, and the numbers don't look as exciting. About 1 out of 9 men, their PSA dropped more than 50%. 6% of these men, you saw a shrinkage of cancer. So the numbers don't look that great. But you got to remember, immunotherapy works somewhat differently than these radiation treatments or chemo. Oftentimes, if you could get stable disease, that is actually a win, because sometimes stable disease can last years. So you're using the immunotherapy to use your immune system to contain the cancer. And I have a guy today, he's had his 30th monthly dose of Keytruda. And his PSA is practically 0. So if you're lucky, you could be, so I'm telling patients there's about a 20-something% chance you'll get some benefit from this treatment. And the goal is stability. And it's these immunotherapy drugs that sometimes come out with these amazing responses that we see in other cancers, including cure. I have a guy who has melanoma, and his cancer was in his brain, perforated his small bowel, and some lymph nodes, and he took a cocktail of immunotherapy, this one actually, Opdivo Yervoy, and the cancer disappeared. He's in remission for 4 years. I anticipate that there will be some amazing responses in prostate cancer with this drug, with this combo. And also Keytruda will be paired up with future drugs to see if we can get better numbers than Keytruda by itself. So immunotherapy, they're just going to keep working on it, and then suddenly we'll have this breakthrough. And I'm hopeful within 3 years. Another class of drug is called what we call the PARP inhibitors. The PARP inhibitors are this class of drugs. They're kind of like an oral chemotherapy. And they work really well against breast cancer and ovarian cancer. And we're finding out that they work in men who have prostate cancer that express a certain type of gene. So either the patient himself inherited a BRCA1, BRCA2 gene, or the Angelina Jolie gene, and it's an autosomal dominant gene that one gets from their parents. And if you happen to have this gene, your type of prostate cancers are actually more aggressive, but they also respond to PARP inhibitors. And this drug is called olaparib. And sometimes you don't have to carry the gene, but the cancer itself can carry the gene. And if the cancer itself has that gene, the patient will respond to olaparib. And this was data presented basically, in 2015, we found that about 2 out of 3 men responded to olaparib if they have those genes. But now they're doing some olaparib plus Zytiga combination, and they're seeing that combination of olaparib with Zytiga seems to be better than Zytiga by itself. Another PARP inhibitor called rucaparib, its data was presented late last year, and they found that of 45 men who had this drug, half of these men had a PSA of greater than 50% decrease. So about a 40 to 50% success rate with this drug, a pill. And especially if you have these inherited or the cancer itself has the BRCA mutation. So this is a promising new class of drug that hopefully will be available. This one might be available in a year or two. So hopefully with this whirlwind of information from early stage to relapse to metastatic, patients you guys will learn how to categorize your own situation and then really bone up on your specific shade and get very proactive and confident when managing your physician. Basically, I said what was on here, so I'm not going to repeat myself. And so hopefully this will help educate you guys and help educate your doctors. So ultimately, if you guys need more information, I'm referring you to the book, these 2 books, and obviously, knowledge is power. Just imagine how much power you have. All right. Thank you very much. Thank you very much.
So what I'm going to do is I'm going to go around and I'm going to, if you raise your hand, we'll prioritize you. So I saw that man first. Go ahead.
Yeah, can you show the slide that had the 3-year tests?
Oh, yeah, yeah.
And were those tests in lieu of a biopsy? Is that correct?
It will help you determine if you need a biopsy. Yes. So,
Next. Anybody else?
Just a minute, he's going back to the chart.
okay, so while you're looking, I could answer whoever's next question.
Any other questions over there?
Yeah. Thank you. My question is kind of abstract in a way, but you know how you can catch mice with a piece of cheese in a trap and they go to that? Okay, in that context, is there any research or anything where you could inject something in the body and instead of having a metastasized prostate cancer go to all over the body, it would go to that trap, or a roach motel, for better words. Like a capsule or something subdermal,
No. I mean, very, very exciting and fascinating concept, but it doesn't work that way.
Okay.
There's no research to be hopeful
Okay,
yet.
okay.
Yeah.
Thought of the
Someday.
going to one spot, you zap it there with radiation, or cut it out and put another capsule in. If it goes again, you just get it there and nowhere else. So,
Keep your fingers crossed.
okay, thanks.
We'll go back to this. Do you have a follow-up question?
No.
Over there.
I'm just curious, is it still the standard of care that when you initially give hormone therapy, you give chemotherapy? Because I didn't notice that in your statement.
So the standard of care, it depends on what the situation the patient is in. So if you have of course, if you have metastatic disease in the beginning, you can, when you give that patient hormone therapy, you either give Zytiga or chemotherapy or both. So that's one scenario where you consider chemotherapy up front. Another scenario where you consider chemotherapy is if your patient has a really bad cancer in the beginning, and you want to do everything you can to give them a better cure rate, then in some cases, giving a short course of chemotherapy will help.
I thought there was a study in the last 2 or 3 years that suggested the advantage of moving chemotherapy from end of life to as soon as you give.
So that study, there's actually two. One is called the Chartered study, and one is called the Stampede study. You are giving chemotherapy at the initiation of hormone therapy for metastatic disease.
Thank you.
Next, over here. Go ahead.
What role, if any, does proton have in this choice?
So proton therapy is a different type of radiation, but it's still very effective at treating the prostate. And so as an initial treatment when you're trying to cure someone. Even proton therapy, they are cutting down their fractions to about 25 fractions as opposed to 40.
Over here. Go ahead.
Is there any definite answer regarding the comparison between intermittent and continuous AKT approach?
So almost all the time, intermittent is equal to continuous. So therefore, you get the advantage of less side effects and treatment holidays to do intermittent. There is a caveat where continuous is better than intermittent, and that's the metastatic setting. So the more cancer you have, the less confident or safe it is to take a break. Think of it that way.
Next. Any other questions? Go ahead.
Is there any evidence that diet or supplements have any meaningful effect on any stage of prostate cancer?
Couple of caveats. One is for low-grade, primarily PSA relapsed prostate cancer with a slowly rising PSA. There are some studies, particularly one a few years ago by Dean Ornish, showing that a low-fat, low-sugar diet seems to slow down the PSA rise. Lifestyle changes are paramount when you're on hormone therapy, because hormone therapy can cause a lot of side effects: weight gain, fatigue, muscle loss, arthritis, and a lot of lifestyle changes can mitigate those terrible things.
Anybody else?
You went through it, briefly. What is your opinion of HIFU and where it's at these days?
So, HIFU is high intensity focused ultrasound. I hope I can sit on this without breaking it.
Get you a chair.
Well, hopefully it'll be okay. HIFU looks promising. In terms of its ability to kill cancer, it looks like it's about 80 to 85% successful. And their selling point is not just treat the whole prostate, but perhaps even treat the cancer itself, doing like focal therapy.
So what would the cryo percentage be?
Cryo, we're also looking around 80 to 90.
Anybody else?
I have a couple. I agree with you a lot of it. You mentioned that 4+3 in contrast to 3+4. Can you explain?
Sure. So the Gleason, as you guys might know, Gleason score is based on the biopsy and what the pathologist determines the cancer to look like under the microscope. Does it look angry or not, basically? And the scale is basically 6, 7, 8, 9, and 10. So 8, 9, and 10 is bad cancer. 6 is good cancer. And the 7s, the 3+4s behave more like 6s. 4+3s behave more like 8s. So I tell people 3+4 is like a Gleason 6.5, and 4+3 is like a Gleason 7.5. So the 4+3s have a higher likelihood of invisible metastasis.
Did that answer your question?
Yeah.
Anybody else? Okay, go ahead.
When you mentioned it, when you mentioned surgeon would be biased as far as their perspective. They're not familiar with radiology and all that, because I went to the second opinion for radiologists. Because I was just wondering how there's a lot of, I didn't know about all these ways to look at treating, and so I'm in the stage of learning a lot to, how do I get the information, or even working with the physician?
Well, you know, it used to be 6 months of digging through Google every day, and I really think Mark's book is very good, and not because I wrote a few chapters in there, but it's really good, and it was smart of him to and he got some really good co-authors to contribute. I think that will help you. So, color stage is for patients like yourself.
So let me add a few things, okay? I think there's, along with what the doctor says, I think, you know, books that have been written by renowned doctors, and I consider him and Lamar a renowned doctor. That's one good source, okay? Other good sources are support groups here, okay? We have an advanced meeting, and we have a newly diagnosed meeting. And one of the opportunities that you have there is there may be 10, 15 people in a meeting, and each person is sharing their successes and their failures. And you learn a great deal just by listening and asking questions in that kind of surrounding. The other thing is that there are support groups online, okay? And you can get a list of those support groups. I'm sure we have sources within our group where we could refer you to those. So it's just not one way. There's multiple ways you can get the information. The internet, books that are written by very successful doctors who really have great expertise in prostate cancer. Going to support groups like ours and other support groups here in Southern California. So the more time you spend, the more you're going to become informed. The more you become informed, the more proactive you can be with the doctors when you meet with them. So what I mean by that is, you know, if you don't have a good basis when you meet with the doctor, then you're you know, trying to figure out what he means by this and what the definition of that is and so forth like that. But if you're informed, you know how to ask intelligent questions and you'll get a greater payback. Yes. What's Mark's book? Where can we get that?
Oh, it's called The Key to Prostate Cancer.
And you can go to Amazon, I would assume, okay, to get the book. Right, Dr. Lamb?
Yes.
Okay.
And one great thing about support groups is you actually get to hear the term radiation proctitis or cystitis or incontinence or impotence. It's just kind of a scary word, but you'll see how it affects people and to what degree when you get to talk to patients. So I think that's very important.
What else? Anything else? I want to thank you for the 18 years of service.